So I want to welcome everybody here to the afternoon amyloidosis session. As you probably know, this is part of an umbrella conference called the Rare Cardiac Conditions Conference. And so we have several specialty meetings going on this afternoon simultaneously. This is the amyloidosis session, which you've joined, and we appreciate you coming here. There also is a sarcoidosis session going on as well, and a few other groups are meeting as well. So for the format of today, the two moderators are myself and Dr. Nowell Fine, who you see there. Many of you, I'm sure, know Dr. Fine. He's probably the leader for cardiac amyloidosis, cardiology-wise anyway, in Canada. Is someone who I knew well being in Alberta, but now I've relocated out east, but we still keep in touch fairly regularly. I thought this would be actually a great venue. I was hoping to get a lot of representation from across Canada. This is a great opportunity to talk about some of the initiatives that he and Margot Davis are spearheading in terms of the registry, and talk about how we can get all sites engaged, because this being a rare condition, we do want to try to grow our knowledge and grow our ability to collaborate and connect with one another. Yeah, any other words, opening words to add, Noel, before we get started on our case presentations?
No, other than saying thank you, Ian, for inviting me and all of our speakers and for organizing this fantastic conference. I think it's a great opportunity to explore a challenging area, which is kind of rare disease awareness in general among our cardiac colleagues. And also, yeah, really nice, this session, nice platform to talk about collaborative measures like the registry, and a few others that we'll talk about. So thanks again for organizing this. It's fantastic. And yeah, looking forward to the session with everybody.
Terrific. Okay, so without further ado, I'll introduce our first speaker. She's someone I've gotten to know well in my 6 months that I've been here. Dr. Mengesha is a cardiac imaging and research fellow at the University of Ottawa Heart Institute. She and I work closely together in cardiac MRI, and she's also doing work in cardiac CT and nuclear cardiology. So I've asked her to present, I do a case presentation of cardiac amyloidosis, and maybe I don't want to steal her thunder, so I won't reveal anything more at this point. So take it away, Dr. Mengesha.
Okay. Hello, everyone. Thank you for this opportunity to participate in this wonderful conference. So,
Dr. Mengesha, I think you're on mute.
Oh, sorry. So I'll start again. Thank you for this opportunity to allow me to participate in this wonderful conference. I have no disclosures. I'll start by presenting a case of a 67-year-old male that with a history of a prior myocardial infarction that presented to us with an acute onset of confusion and dysarthria. On physical examination, he had expressive aphasia. Otherwise, he didn't have any focal neurological deficit. His blood work did show persistently elevated troponin with no significant change and an elevated NT-proBNP. His ECG, as shown here, was in sinus rhythm. He had bifascicular block, and also the QT and PR were borderline prolonged. He later on underwent CT angio and MR angio of the brain, which showed us an acute focal parietal cortical infarct. And on the CT angio, we were able to see an occlusion of the M2 branch of the left middle cerebral artery. And looking at the vessels, he had minimal atherosclerosis. So the working diagnosis was CVA, most likely to be of cardioembolic source. And he underwent the next the next study, which was echo. So as we can see here, his echo showed a concentric LVH with wall thickness measuring up to 17 millimeter. The function was also the systolic function was mildly reduced with a regional wall motion abnormality. And as you can see on the apical segments and the anterior septal and apical segments, the wall is relatively thinned, and the function the segment was also hypokinetic. Looking at the diastolic function on the left, we can see that he had a restrictive filling pattern. Unfortunately, the images are not playing well. Okay, so looking at the strain analysis, we see that it's globally abnormal with a relative sparing of this small area, the septoapical region. But looking at this, we don't see the perfect apical sparing or cherry on top pattern seen on cardiac amyloid. But I would like to remind everyone that this patient had a prior infarct in the LAD territory. So in summary, we have a patient with that presented with stroke and a finding of concentric LVH without clear cause. The patient is not hypertensive. He does not have aortic stenosis. So we have this concentric LVH, and he has a significant diastolic dysfunction and persistently elevated cardiac biomarkers. So this raised suspicion for cardiac amyloid. So my question to the audience is, which one of these tests would you order next? You can take a poll. I'll give you a few seconds. I'll give the answer to this question in the following slides. Okay, so I'll move forward. So let's talk about the red flags. I'll start with the ECG. So we commonly see this low voltage or pseudo infarct pattern that's been described. And we have an example of it here. But this low voltage pattern may not always be found. Actually, in 30% of patients with cardiac amyloid, we may not see this. And its sensitivity is somewhere between 40 to 50%. On the other hand, finding of low voltage in the presence of a thickened LV wall on imaging, that discordance is actually to be more sensitive in detecting amyloid. So when we see a LV wall thickening in true hypertrophy, as in a hypertrophic cardiomyopathy, since the cardiomyocytes are hypertrophied, we get this typical high voltage pattern. Whereas in cardiac amyloid, we get this pseudo hypertrophy or appearance of thickened wall because of the expanded ECV that's infiltrated by the amyloid. And the cardiac myocytes themselves are not hypertrophied. As a result, we have this low voltage. So when we see low voltage with a thickened LV wall on imaging, this discordance is actually very sensitive. Conduction abnormalities and atrial fibrillation are quite common as well. The other red flags we should look for on imaging on echo. So an example would be to find LV wall thickening without a clear cause. That serves as a clue, but it may not always apply since many elderly patients with cardiac amyloid have concomitant hypertension or aortic stenosis. So we have to keep a high clinical suspicion in such cases. Other clues may include thickening of the various cardiac structures. That includes the RV wall as well, or the interatrial septum, or the valve leaflets. We also need to look at the diastolic dysfunction in early or less advanced disease. We may find a grade 2 diastolic dysfunction, but as the disease advances, we see this typical restrictive filling pattern and also this 555 sign, which stand for the reduced velocity in tissue Doppler, where the A prime, E prime, and S prime are all less than 5 millimeters per second. The typical cherry on top pattern seen on the strain imaging or the relative apical sparing can be seen as well. But we also need to remember that patients may have concomitant coronary artery disease, and if they have a prior apical infarct, such as our patient, we may not get this typical picture. Regarding aortic stenosis, it was found that 16% of patients who underwent TAVI were found to have cardiac amyloid, and 30% with low flow, low gradient aortic stenosis were found to have cardiac amyloid as well on tissue diagnosis. So this can also serve as a clue, in our patients. We may also see mild small pericardial effusion. So on top of the imaging clues that we've discussed so far, other clinical clues that we need to look for could be intolerance to beta blockers or AC inhibitors, or it could be a patient that was previously hypertensive, now may not tolerate his medications, or may need to stop with blood pressure medications. So these patients, as we know, usually have autonomic dysfunction and may have orthostatic hypotension. So all of this can serve as a clue. In addition to the bilateral carpal tunnel syndrome that we look for in these patients, we have to ask also for other musculoskeletal findings. It could be lumbar spinal stenosis or bicep tendon rupture or prior knee or hip replacement, which can serve as additional clue for ATTR. With AL amyloid, they usually present with cardiac involvement or nephrotic syndrome, but there are other specific findings that may help us, such as macroglossia or periorbital purpura, and so on. So once we suspect cardiac amyloidosis, the first step really is to rule out AL amyloidosis by screening with the serum and urine electrophoresis and immunofixation. This is because the downstream cardiac imaging, be it cardiac MRI or cardiac scintigraphy, it's not able to differentiate definitively between AL and ATTR. In our patient, the protein electrophoresis was normal, so the next test that was done in this case was cardiac MRI, which showed us concentric thickening of the LV wall, especially in the basal segment, as we saw on the echo. In addition, we were on tissue characterization. We were able to see increased T1 times in DCV. We were also able to appreciate subendocardial circumferential LGE, as well as patchy mid-myocardial LGE, and also this LGE on the RV aspect of the septum. And if you can see here, there's also LGE in the atrium as well. Finally, when we look at the look-local sequence, we appreciate the abnormal nulling pattern seen in cardiac amyloidosis, which I'll describe in my next slide. So the red flags on cardiac MRI, as I've mentioned before when we discussed the echo findings, could be thickening of the cardiac structures. In addition, we have the advantage here in MRI to characterize the tissue. So we usually see these significantly high T1 times and ECV, which are suggestive of infiltrative process. On the other, in addition, in look-local sequence, we see this abnormal gadolinium kinetics. So normally, post-gadolinium, the myocardial signal intensity, we usually see that because the blood pool contains a higher concentration of gadolinium, it passes through the nulling point before the myocardium, so it appears to be dark before the myocardium. But what happens in cardiac amyloid is that the myocardium it's infiltrated, and the nulling signal of the myocardium actually occurs before the blood pool, and it may appear as dark, or it may be coincident. So this reverse or coincident nulling pattern is typically seen in amyloid. Although the CMR is highly sensitive in detecting disease, it cannot be used to differentiate between the amyloid subtypes. The next study that was done for our patient was cardiac scintigraphy. So it's usually recommended imaging modality in suspected ATTR amyloid. So in this scan that was done for our patient, the bone AV tracer PYP was injected, and we scanned the patients 1 hour and 3 hours after. So what's recommended is to do a planar imaging and a SPECT imaging as well. As we can see on the planar images to our left, we do a quantitative assessment by measuring the mean counts on the region of area, comparing the HERT to the contralateral lung ratio. The ratio at a 3-hour scan normally should be less than 1.3. And in our case, in this patient's case, was 2. Also, looking at the visual assessment of the cardiac uptake compared to the bone, we see that there's quite a significant cardiac uptake in this case. So looking at the cardiac scintigraphy findings, the semi-quantitative or the visual comparison of the cardiac to bone uptake as per Gini score, as you know, a grade 2 or a grade 3, meaning the cardiac uptake to be as well as the bone or the ribs, or more than that, is highly suggestive of cardiac amyloid. Although this test is highly sensitive and specific, it may also be positive not only in ATTR, but in AL as well. So typically, we use also SPECT imaging using these bone heavy tracers. Could be PYP, DPD, or HMDP. Although it's not clearly understood, it's believed that the phosphate in the tracers bind to the TTR, which has a high calcium content. Although not clinically used on and more of in a research world, there's also PET tracers that have been developed to image cardiac amyloidosis. So one of the diagnostic pitfalls we've learned is doing cardiac scintigraphy using only planar images and not doing the SPECT. So that's one pitfall, because as you can see, there may appear to be a cardiac uptake, where on SPECT, we see that that was actually a blood pool and not the myocardium. So we always need to do a SPECT image as well. So it's mandatory in differentiating, the myocardium from the blood pool. So the AAC consensus statement that was published 2 years ago suggests that in AL amyloid, once there is a clinical suspicion and imaging findings supporting that, we need a tissue biopsy or for definitive diagnosis. Whereas in ATTR, we have the option to make the non-invasive diagnosis based on suggestive clinical findings, as well as imaging findings on cardiac scintigraphy. Now, this paper did suggest the use of cardiac MR as an additional imaging modality to support the diagnosis of ATTR amyloid. But when we look at the most recently published ACC consensus statement, they actually do not include cardiac MR. Instead, they emphasize on the need for a cardiac scintigraphy as the imaging modality to make a non-invasive diagnosis for ATTR. So that was all. I have a few points for discussion, and thank you for your attention.
That was great, Betty. So yeah, maybe I just sort of get the flavor of the room. I was at an MRI meeting a month ago when this position statement came out. Can you slide back to that slide, Betty? Yeah, where where there's MRI doesn't appear on this expert document anymore. So I just sort of wondered people's thoughts about that in the room. I'm surprised it doesn't even show up on the AL side of the equation. Can understand perhaps maybe why not on PYP, but anyway, scroll back to your questions. Okay, so maybe we'll work our way through the questions, and then we'll build up to the last question. Is when you suspect cardiac amyloidosis, in terms of cardiac imaging, who do people here think that echocardiography is usually always the first imaging modality of choice? What would you say to that, Nowell?
Yeah, I think so. I mean, our Canadian guideline kind of recommends a standard workup for heart failure, and that's generally, you know, recommended as kind of initial screening, even if the initial presentation isn't heart failure. You know, we still kind of follow that initial recommendation algorithm, and as the other tests, the routine tests, X-ray and labs and ECG, etc. So I think all patients should get an echo, in addition to, you know, it gives us some valve information, and, you know, is generally widely available test. So I would say yes. I can say I have some thoughts on the MRI comment, but I can save those for when we get to them as well.
Okay. Yeah, that sort of comes up maybe in the last question.
Yeah.
So yeah, I would agree. Like it would be very rare, I think, that you wouldn't do an echo as the first line imaging modality, in my opinion, as well. So I guess the second question, and Nowell knows this was a point of debate in Alberta for a while, and then also in Ontario until recently. Does a cardiac pyrophosphate scan obviate the need for endomyocardial biopsy? Are there any places in Canada now that still require endomyocardial biopsy to be eligible to receive a gene silencer or stabilizer therapies? Is there are? Where's that, Noel?
Yeah, I can't speak for every province, but as you know, this was part of a lot of the provinces adopted this requirement based on CADTH recommendations, and so I think most of them have changed. You know, CADTH came out with a statement to their credit saying that they would lift those recommend lifting that requirement. The provinces, of course, make their own decisions with regards to public access and funding, but it was very helpful to have CADTH lift that recommendation after kind of an outcry from the amyloid community saying, the standard of care has shifted and this is no longer clinically indicated. So I believe most provinces, I don't want to speak out of turn in case I'm not remembering something, but I believe so.
Yeah, I think Ontario also recently changed their rules around that, so you don't need to do biopsies anymore to be eligible to receive targeted treatment. And then the last question, which in my mind sort of addresses that recent recommendation. So if you have a bone marrow biopsy that reveals amyloidosis, and you have a CMR that is consistent with cardiac amyloidosis, do you still need to perform an endomyocardial biopsy? My answer to that is no, but I don't know, Noel, would you still do an endomyocardial? Like I'll tell you, Noel, it's so rare. I would say that I do endomyocardial biopsy. The only times I would be if the imaging was equivocal, like we didn't get a clear answer from the imaging.
Yeah, I'd agree, Ian, and often that's the case with us as well. We do very few endomyocardial biopsies now, and for AL patients, usually we can get our answer. I think Dr. Visram has her hand up, so I'll let her weigh in because she's an expert. Sorry, I'm just getting an echo. Hear that. Voice twice. The only comment I'll make is that we do use MRI routinely for our suspected AL patients because I do think it provides some additional value beyond just diagnosis and gives us some information about the extent of cardiac involvement. Most patients that we see, we kind of, we know that cardiac involvement is very common in AL. More than half of patients will have it. And so, for us, at least on the cardiac side, our question is not so much whether it's there or not, but how severe is it, right? And how
so you know what, Noel, you'll see the answer to my question on the last case that's being presented.
Okay, I'll shut up and let Dr.
Well, that maybe Alissa, maybe.
Yeah, so just from a hematology perspective, which is very different than what you guys are considering, but in terms of the bone marrow, so if the bone marrow does show Congo red, that's helpful because you can do the isotyping and that'll help you differentiate AL and TTR. But also if the clinical picture fits, you know, TTR doesn't usually have renal involvement, so if they have nephrotic syndrome or proteinuria, that's helpful and it's reassuring. We wouldn't push for an endomyocardial biopsy. But the fat pad and bone marrow aspirate have a 90% sensitivity to detect Congo red. So there is still 10% of people, if the clinical suspicion is high that they have cardiac amyloid, in order to get funding for daratumumab Cybordi, which is our first line therapy for AL amyloid, the CCO actually mandates that you have Congo red proof on pathology. So in those situations, we do still push for an endomyocardial biopsy, even if the clinical story fits.
That's very helpful. I didn't know that. Yeah. Okay, great discussion. For sake of time, why don't we move on to our second presenter? Alissa, did you have something else you wanted to know? Okay, we'll move on to our second presenter. So that's Waseem Hijazi. I hope I pronounced that correctly. Waseem is a cardiology resident at the University of Calgary, and he will also be presenting an interesting case of cardiac amyloidosis.
My name is Waseem, and you did pronounce my name perfectly. Thank you for that. I'm a PGY5 adult cardiology resident at the University of Calgary, and I wanted to share a case that was quite educational for myself and hopefully will generate some good discussion points. I have no relevant financial disclosures. So the objectives for this case review are to introduce a case of cardiac amyloid with associated imaging and clinical findings. We already had a great primer on that, so I may not spend too much time on that aspect. We'll discuss the targeted investigations for this particular case, and then review treatment options for cardiac amyloid and transitioning between therapies. So here's a vignette of this patient, Mr. M. He's 73 years old. He, in his 70s, presented with progressive peripheral edema and required furosemide and stockings to help with that, but despite that, developed shortness of breath and progressive symptoms. On examination, he was quite overloaded and he was hypertensive. He had no prior cardiac history. He had a history of dyslipidemia only and was on rosuvastatin for that and candesartan for some hypertension as well. So for objective number one, I wanted to review briefly different types of amyloidosis. We've heard a little bit about AL and AA amyloid, which are systemic amyloidoses. AL amyloid involves the heart in 50 to 75% of cases, some of which may be asymptomatic. AA amyloid almost never involves the heart. And transthyretin amyloidosis is the most common amyloidosis that we encounter as cardiologists. And of that, there's two types. There's a wild type, which involves correctly synthesized transthyretin monomers from the heart that interact adversely with tissues and fold inappropriately. This is most common in elderly patients. And then there's also mutated TTR protein, which involves a mutation in synthesis at the level of the liver of transthyretin, which has similar manifestations. You can see that the median survival for the hereditary form is a striking 2 years, which is portends a very poor prognosis, and 4 to 6 for the wild type. As we just heard, the recognition of ATTR amyloid is exploding. You can see with time, this has been much more diagnosed as a condition, and probably cases that were described as diastolic dysfunction or hypertensive heart disease nowadays are more recognized for what they truly are. There is a higher proportion of patients who are getting TAVR who have cardiac amyloidosis. And in fact, greater than 10% of all HFpEF in people older than 60 is cardiac amyloid. In the setting of wild-type transthyretin amyloidosis, we can see that a TTR mRNA is made in the liver. It's synthesized, translated, has post-translational modifications, but there's misfolding of this protein that results in aggregates of amyloidosis that typically, in the case of ATTR wild type, cause cardiac manifestations in the heart or autonomic manifestations, peripherally speaking. For our patient, this was the echocardiogram. So you can see there's a septal and posterior wall hypertrophy in a concentric matter, a small LV cavity size. There's significant tricuspid regurgitation with a jet occupying a large area of the right atrium. You see here that there's an RVSV of 80 millimeters of mercury, consistent with severe pulmonary hypertension. On the apical four-chamber review, you note the exquisitely enlarged atria, bilaterally speaking, and this patient was in atrial fibrillation. Thickening of the valves, a speckled appearance of the myocardium. Despite that, LV systolic function was preserved. When you look at the strain imaging, you can see that in the basal to mid segment, there's reductions in longitudinal shortening, as well as at the apex preservation, which is the so-called cherry on top pattern that is actually in the literature quite described and validated as a measure of cardiac amyloidosis. So in this specific case, this patient went on to have further imaging from the CCS guidelines in 2020. We have here published recommendations for whom should be screened for cardiac amyloid if they're presenting with heart failure. And unexplained LV wall thickness is one, being older than 60 with low flow low gradient AS is another, unexplained peripheral sensory motor neuropathy, bilateral carpal tunnel syndrome, and established AL or ATTR amyloid. So this patient actually had two of these so-called warning features because of the unexplained LV wall thickness and the neuropathic symptoms that they had manifested. So back to the case, this patient required increasing doses of furosemide to obtain euvolemia. This is an example of a positive PYP scan, which was ordered for this patient and positive. This patient also had serum free light chain ratio and protein electrophoresis, which were negative for a monoclonal protein. So at this point in time, the suspicion that this was ATTR amyloid was extremely high, but the patient did go on to have a bone marrow biopsy. This was back in 2021, which was positive on Congo red staining for amyloid fibrils without any clonal population in the bone marrow. So back to this case, we have two options for what this patient could have. Is it wild type transthyretin amyloid, or is it a mutated form or hereditary amyloidosis? This patient was of Jamaican heritage, and we do know that this particular population of people has a higher rate of a particular mutation called the PV142I mutation. So basically a valine to isoleucine mutation. And this patient had genetic testing and was in fact positive for this gene mutation. And if you look at the CCS guidelines for what you should do in terms of the workup for this, when you have a suspicion of ATTR amyloidosis, performing genetic testing is recommended to differentiate the two. And there's quite significant, I think, research and knowledge gathering benefits to knowing if a patient has genetic transthyretin amyloidosis, but also it's inherited in an autosomal dominant fashion. And so there's genuine benefits to counseling that patient and their family members about the risk of developing disease and perhaps very early monitoring for said people. This wild type ATTR amyloid mutation that I just described, the V122I, is the most common mutation in Canada and the United States. Around 3 to 4% of African Americans do have this mutation. However, there is quite variable penetrance and expressivity of the mutation, and therefore it can be quite variable how one manifests the disease. In Europe, there's other mutations that are well known to cause amyloidosis. So the Val30MET mutation is probably the most common one in Europe and Japan. And interestingly, this particular mutation is associated with neuropathy phenotype much more strongly. So There's 144 mutations though, and I think knowledge on this is rapidly expanding. So for our final objective, we're going to look at treatment options. So here's a question. This patient has NYHE class 3 symptoms and mild sensory neuropathy. Which of the following therapeutic approaches is most appropriate to consider for this patient? Would it be furosemide and candesartan? Would it be patisiran, an mRNA silencer? Would it be tafamidis, tetramer stabilizer? Would it be a liver transplant, or would observation on its own be appropriate? And we'll take a look at some of the evidence behind the disease-modifying therapy and make a decision about what is most appropriate, and we'll tell you what happened to this patient in our amyloidosis clinic. So essentially, when this patient presented in 2021, the initial presentation was volume overload. The patient required admission to hospital. They needed IV diuresis, and they were quite volume overloaded. They could not tolerate high doses of afterload-reducing agents. About a little bit of candesartan was about the most that they could tolerate despite the hypertension. And the reason for that was significant orthostatic symptoms. This patient was followed by neurology and cardiology in our amyloidosis clinic. He had EMGs to look for carpal tunnel syndrome and radiculopathy as the patient was beginning to complain of sensory symptoms. A decision was made, given the predominant heart failure phenotype initially, to start the patient on tafamidis therapy. And the patient had some modest improvement. Their NYHA class went from 3 to 2. They weren't admitted to hospital in the interval year, which was also a significant benefit. That said, they were still symptomatic and required relatively high doses of furosemide. Evidence from tafamidis comes from the ACT trial. This is a transthyretin stabilizer. It doesn't affect the synthesis of the protein. However, it does make transthyretin less liable to deposit in tissue and causes end organ manifestations. So this was a multi-center randomized trial of tafamidis versus placebo, and it did actually show lower all-cause mortality. In addition to that, it showed reduced cardiovascular outcomes and improved functional capacity at 30 months. And this was a relatively, high relative risk reduction between tafamidis and placebo in this trial, hence the decision to use it in this patient. So essentially, the free tetramers are liable to become misfolded and then deposit into tissues as fibrils. But the idea is that tafamidis would be able to stabilize the tremor and prevent that deposition of tissue. However, this patient did have some benefit with tafamidis. His LVF improved on MRI to 55% from 41% on the previous MR. However, the LGE burden stayed the same. I think that's logical. We're not expecting necessarily tafamidis to reverse areas of already deposited amyloid fibrils, but the patient then went on to have very significant neuropathy symptoms. So typically with amyloidosis, sensory neuropathy is followed relatively quickly by motor neuropathy, and there's a strong component as well of autonomic dysfunction. So the patient began developing painful sensory neuropathy that was interfering with functional status as well as his sleep. He also had bilateral carpal tunnel syndrome, despite being on tafamidis therapy. And I'll note from the ACT trial, there wasn't any outcomes that were geared towards the neurological manifestations of this disease. So looking at the CCS guidelines, again, there's a few different therapeutic disease-modifying therapies. So we can consider a liver transplant for hereditary ATTR given the origin of the disease. We can consider inotersen or patisiran for patients with polyneuropathy symptoms, tafamidis for the heart failure symptoms, or if it's AL, which in this case it was not, chemotherapy. So let's take a look at the mRNA silencing options. So this works as a completely different mechanism than tafamidis, but it essentially prevents the generation of hepatic TTR at the level of the liver, and both the mutant and wild type copies are affected. This was studied in the Apollo 3 trial, And we see from this Apollo 3 trial, patisiran was studied in a randomized control trial, and patients were randomized to placebo. Tafamidis and patisiran were never compared head-to-head. This trial did not look at cardiac outcomes, but it looked at neurological outcomes using the neuropathy impairment score. And there was significantly improved neuropathy in patients with ATTR compared to those on placebo. There was better quality of life. This is given as an infusion. The most common reaction was an infusion reaction. These were not anaphylaxis. They were mild and well tolerated, but they did occur in 10% of patients. Even though there's no hard cardiac outcome data, an exploratory analysis of this trial did show that cardiac parameters did improve with patisiran. So there was decrease in mean LV wall thickness, GLS on echo improved, and diastolic volumes were less, and then the cardiac output improved with patisiran as well. Of course, this is just hypothesis generating, but certainly promising, and I think there would be biological plausibility that it would be beneficial as well. So what did we do with this patient? There's no good, clear guideline data on what to do when someone has ongoing manifestations of amyloidosis despite first-line therapy. There is an expert opinion document that's well cited from this Journal of Rare Diseases, as well as there's an ESC expert opinion document as well, but no formal guideline or certainly no clinical trial data to guide what to do in this complex situation. But looking at this expert opinion, essentially once treatment's initiated, very frequent assessment is paramount. So every 6 to 12 months, which is what we do in our amyloid clinic after initiating disease-modifying therapy. And then it emphasizes as much objective clinical data as possible to guide treatment response. And in this case, we did have EMGs showing that the patient was having new neuropathic symptoms, new areas involved in new nerves becoming affected, as well as combined with his significant decline in functional status. We decided that it would be quite important to transition this patient to patisiran from tafamidis, as his cardiac symptoms had stabilized and the neuropathy symptoms had become more significant. We do know the most common cause of death with transthyretin amyloidosis is from heart failure or cardiac dysfunction. However, the neurological manifestations are also quite significant, as they can be rapidly progressive and result in disability in as little as 3 to 5 years, or even less than that, with a high degree of people becoming functionally incapacitated secondary to that. So we did switch this patient to patisiran, and he did actually have improvement in his neurological symptoms with stable cardiac status. So going back to this kind of thought question, I don't think furosemide or candesartan would be appropriate, given that we know amyloidosis is rapidly progressive and associated with significant dysfunction and mortality. A liver transplant for this patient at the age of 73 would be rather wishful, and both patisiran and tafamidis, depending on the disease phenotype, are appropriate, and it's a rather complicated multidisciplinary decision. So for my take-home points, transthyretin amyloid is the most common type of cardiac amyloid. Disease-modifying therapy exists for this and should be tailored to treating either a cardiac or neuropathic profile. And cardiac benefit profile is more robust for tafamidis and is more exploratory for patisiran. And I think multidisciplinary decision-making is really quite paramount here. Thanks very much.
It was an excellent presentation, and highlights some of the difficult choices healthcare teams and patients need to make. On the one hand, we have a therapy that's been shown to improve outcomes for these patients, but on the other hand, they may have a debilitating symptom arising from other features of the disease, and we have a therapy that treats that. So these are difficult choices to make, and maybe you know, I maybe François or someone can comment about. So there's some trials, I believe, that are looking at combining silencers and stabilizers. Or Nowell, François?
Yeah, absolutely. So currently, people are thinking, should we try to associate some of this drug in some specific patients? So there's ongoing trials who are, somehow testing this hypothesis. We know also it's already happening in some countries where some patients will receive tafamidis and a silencer. But there's also the question of cost of this kind of strategy, which is for a country like Canada a main issue.
Anything to add, Noel, to that?
Yeah, no, I mean, these cases are tough, and there's really not good evidence to guide us on how best to manage cases like this. And so we're kind of using our clinical intuition, I guess, and reasoning and making it up as we go. And I'll talk more about this when we talk about real world evidence and the registry. Yeah, no, it's happening in the US, dual therapy. I know there is a thought that it's without evidence, it's hard to really support it, although, evidence to support it is going to be tough to find. And as François mentioned, the cost makes a very hard case for doing it without good evidence to support it. And so I think we're going to struggle with patients like this that Waseem presented, a nice presentation, Waseem, for a little while. And the field will continue to evolve with new indications for the therapies that are existing and new therapies also becoming available. So, but I think we got a few years to wait, and we'll see. How other sites kind of manage patients like this.
Okay, sounds good. Okay, Kai Wu, he's a cardiology resident in Edmonton, University of Alberta. And he's going to present a case that I was involved with up until the time I left. And to be honest, this case was very thought-provoking for me, and you'll see why in a moment. I'll never forget this case, but and this is also a case of AL amyloidosis, because we've had two ATTR cases, so I thought it would be great to balance things out a little bit.
Okay, awesome. All right, can everyone see the slides here? So this is a presentation. Thank you for this opportunity for me to present this case. So this is a 43-year-old gentleman presenting with shortness of breath and dry cough for many months. He was initially very healthy, played hockey and biked regularly. He was sent to the emerge after his family physician ordered a CT scan, which turned out to be abnormal. He has no past medical history besides being an ex-smoker and quit many years ago. He currently works as an operations manager, and he has no alcohol or recreational drug use and is not on any medications. His physical exam revealed he had normal blood pressure, but he was tachycardic. His elevated JVP to the angle of his jaw. He also had displaced apical impulse, a pitting edema to his shins, prominent S3, and crackles to his basis on lung auscultation. His non-contrast CT revealed moderate lucency throughout his skeleton, involving his sternum, ribs, and thoracic spine. He also had a subsequent skeletal survey, which discovered multiple osteolytic lesions concerning from multiple myeloma. This was his ECG, which showed Q waves in the lateral leads and also poor R wave transition. He had an echocardiogram done at baseline, which shows severe concentric LVH with EF of 40%. And also RV dysfunction, grade 3 diastolic dysfunction as well, with no significant valvular pathologies. He ended up having an MRI in hospital, which showed moderate severe concentric LVH with an EF of 26% and also reduced RV function as well. He had his gadolinium uptake, which showed diffuse enhancement of right and left ventricle, pronounced in the subendocardium, concerning for cardiac amyloidosis. He ended up having some blood work done as well. He had an elevated CRP. His SPEP and UPEP show presence of free light chain in a beta region, and his serum free light chain ratio was markedly elevated with a free kappa light chain of 1700 and a ratio of 267. He had a bone marrow biopsy done, which showed plasma cell myeloma involving 75% of his cellular marrow, and the Congo red staining was positive as well. So he was diagnosed with high-risk Mayo stage 3 AL amyloidosis, complicated by multiple myeloma and multi-system involvement. He ended up having chemotherapy with CVD times 9 cycles, and then he responded well, and he ended up having autologous stem cell transplant 6 months after. So he was currently managed on lenalidomide. So in interest of time, we won't go through a poll for this, but which test would you order for cardiac amyloidosis? Now, in terms of the biomarker trends, so as you can see here, for biomarker follow-up, we follow for cardiac biomarkers and also hematologic biomarkers. And starting with the cardiac biomarkers, his NT-proBNP was markedly elevated. And then after starting chemotherapy and also after his stem cell transplant, his NT-proBNP dropped significantly. Same thing for his serum-free light chain ratio. As you can see, the top first value for serum-free light chain is off the chart, and then it sort of drops down, and it remains around 2 or less. Similarly for his CMR surveillance, so as you can see on the left graph here, the blue shows his LV mass in grams. Initially, you can see that his LV mass was elevated, and with time and with treatment, it dropped significantly. Similarly, for his LV and RV function, those started at less than 30%, and in the end, our most recent follow-up showed that his ejection fraction was above 50%. Similarly, for his T1 values, so when he first started, it was 1180 milliseconds. And with treatment and time, it dropped to below in the normal range. Now, in terms of AL amyloidosis treatment, so this is a collaborative effort between hematology, oncology, and cardiology. And this is just a slide from the ESC demonstrating a treatment regimen where patients are decided they're eligible for a stem cell transplant. And if they are, they undergo the left panel here with high-dose methylene. And then if they're not, they undergo Cybor-D and DARA treatment. Now, the suggested ASCT eligibility criteria is actually quite strict based on the ESC criteria. And in terms of prognosis, this is also taken from the ESC, but there's 2 scoring systems for AL amyloidosis using the updated Mayo as well as the Boston University. And essentially what you see here is that what's important in the staging system for amyloidosis is the cardiac involvement. So Boston University uses troponin I and the regular BNP, whereas for Mayo, they use troponin T and NT-proBNP. In terms of survival, so this is sort of depending on what their response is, and each of these categories has their own response in terms of what their hematologic response is, and that's associated overall survival. And then there's also a percentage of cardiac response as well based on echo parameters. Now, what is the role of the cardiologist in managing AL amyloidosis? So the cardiologist is heavily involved in terms of initial cardiac assessment, heart transplant evaluation, and also cardiac monitoring during and after chemotherapy. In terms of follow-up biomarkers and imaging, so this is an area where there's no good studies to suggest one way or another. The hematology team often measures a regular serum-free light chains, SPEP, UPEP, and other hematologic parameters. But in terms of the imaging monitoring, depending on which guideline you look at, so the ESC suggests every 6 months visits with ECG, blood work, and yearly echoes and 24-hour Holters. The CCS, they sort of provide you some guidance about serial imaging, echo, or MRI, in addition to measuring NT-proBNPs or BNPs, but there's really no sort of frequency provided. The ASNC guideline just says that there's a report with ranges between 6 to 48 months. There's no good evidence for serial imaging. And this is just an example of the ESC recommendation here. And given the interest of time, we won't go through, but there's just some small case studies talking about what what they found on cardiac imaging in terms of patients who are treated for AL amyloidosis. So in summary, AL amyloidosis is a rare disease requiring collaboration between hematology, oncology, and cardiology. And the prognosis is dependent on, mostly influenced by cardiac involvement using the Mayo or Boston University staging systems. And the management of AL amyloidosis requires light chain reduction therapy and management of cardiac complications. Serial CMR may be helpful to monitor the effects of AL amyloidosis treatment. Thank you.
And then do you have questions on the next slide, Kai?
Yeah, so our questions are, is AL amyloidosis a curable disease?
Okay, so let's stop there. I'm going to be honest with the people in the room here. This is so striking to me. This is a fellow who showed up with an EF of 24%. His heart was very thick, and his T1 values and GAT uptake were very striking. I would have never, ever imagined his heart to normalize. I have never, I think I have one other case, Nowell, where this has happened, but it is so rare. And he's now, what are we? He's now 8 years out from his transplant, or maybe 7 years. So this changed my opinion, actually. This case changed my opinion about how well people can do. And this sort of gets to your question, Nowell, about, is there a value to CMR? In this case, I thought there was, just because we've been able to document the disease slipping away from his heart, like over time.
Yeah, it's a fantastic case, actually, really, really remarkable. And I think, we've had some cases where certainly we've seen improvement. I don't think we've seen one that's dramatic as this, though. And it kind of illustrates how the longer term data, particularly, for cardiac, for AL, it's still a work in process, especially as the therapies continue to evolve. And I think Dr. Visram will talk to us a little bit more about that. We are seeing reports of these types of responses from other centers around the world as well. And so I think, yeah, it makes a nice case for serial imaging. The frequency is still uncertain, but it's a fantastic case, and I think we're still learning about it, and it challenges our our existing paradigm about amyloid and its treatment, and kind of what the long-term outcomes will be in these patients.
Yeah, so I've told Kai we have to write this case up for sure. And we'll ask you to be a reviewer since you like it so much. No, and so anyway, the other reason to bring this case up was just to highlight what is the optimal duration and frequency of follow-up, what tests we should be doing. Should we be doing different tests depending if it's ATTR versus AL? Nowell, does your group do a different monitor testing depending on the phenotype, or depending on the type of amyloidosis?
Yeah, I think we do serial MRIs on patients on treatment for ATTR and AL. There's still a lot of controversy in this area, and you can, I've heard arguments against that, and of course, most treatment centers are in areas that have good access to CMR. We're fortunate in that regard, but access is still, I think, somewhat variable. So I wouldn't say that our approach is the one right approach. We found it is helpful, but I think I would just leave it as saying there is a lot of variability across high volume amyloid centers globally with respect to this, and you'll see lots of differences of opinion across internationally recognized experts on how best to do this still. So still very much a work in progress, I would say.
And then maybe lastly, before we hear from our next speakers, Alissa, do you have any comments about this case? Have you seen cases like this where someone get a transplant and improves so much?
Not to this extent, but you definitely do see improvements. I think that it's quite impressive that this patient actually made it through a transplant to begin with in the upfront setting. Usually we wouldn't transplant someone as severe as him, but I haven't seen this much of an improvement, no. I have, sometimes when you get a really deep response with first-line therapy, and then after a few years, people can definitely improve enough that you can consider a transplant in a second-line setting at relapse, but this is impressive.
Yeah, I thought so. All right. Well, with that, maybe we'll move on to our next session. So I'll pass the moderator baton over to Nowell.
Great, thanks, Ian. Okay, so we're moving on. It's my great pleasure to introduce our next speaker, who's my friend and colleague, Dr. François Tournoux. Dr. Tournoux is an associate professor at the University of Montreal and the Faculty of Medicine, and is a cardiologist at the University of Montreal Hospital, or CHUM. He's also the director of their amyloidosis clinic there. He is an FRQS clinical researcher who works on developing new technologies and strategies to transform heart failure management and patient experience, with a focus on cardiac imaging, artificial intelligence, telemedicine, exercise, and amyloidosis, and is also the president of the Quebec Heart Failure Society. Dr. Tournoux did his cardiology training at the University of Paris in France, and also did echocardiology fellowship at Mass General Hospital in Boston, and is widely recognized as an expert in heart failure, imaging, and amyloidosis, and is going to talk to us today about ATTR clinical trials. So thanks for joining us today, François. I'll hand it over to you.
So thank you very much for having me today at this conference. For the next 12 minutes, I have been asked to talk about emerging therapies for ATTR amyloidosis. Amyloidosis has been the source for the past 5 years of incredible technological development, and it's not over yet, as I'm going to show you today. Here are my potential conflict of interest. I got speaker fees and/or research funds from these companies involved in the treatment of ATTR amyloidosis. I am also involved in 2 clinical trials studying some of the drugs I'm going to talk about today. So there are currently 3 groups of drugs we identify to talk about treatment for amyloidosis. We have the TTR silencers, we have the TTR stabilizers, and finally we have the anti-amyloid therapies. In each group, there are drugs which are either commercially available or under development at different stages. We are going to have a look at each group, describe what is currently available for our patients, and what is tested in research protocols. So we are going to start with the TTR stabilizers. TTR stabilizer represent a group of pharmacotherapies designed to inhibit the dissociation of TTR tetramers to monomers and prevent misfolding, deposition, and aggregation of amyloid fibrils. This group includes, of course, tafamidis, which binds to tyrosine binding sites on the transthyretin protein, but also the non-steroidal anti-inflammatory drug diflunisal. To my knowledge, tafamidis is currently the only one which is commercially available in Canada. Diflunisal is not available, I think, since 2020, at least in the province of Quebec. And anyway, it's used to treat ATTR patients, was off-label. Now, there's something interesting. There's a super stabilizing mutation called T119M, which has been identified and which protects carriers from the disease. In fact, this variant reduces the dissociation rate of the tetramer by over 33-fold compared with the wild-type one. Studies have shown that this enhanced stability is likely due to the formation of hydrogen bonds, and an American biotech has developed a new TTR stabilizer called acoramidis, or AG10, and it binds to the TTR tetramer, mimicking the structural influence of the protective T190M mutation. In fact, AG10 forms the same hydrogen bonds we were just talking about. AG10 is currently in late-stage clinical development in patients with familial or wild-type ATTR cardiomyopathy. It's studied within the ATTRibute-CM trial. For some of you who heard about this trial, primary results show that this drug didn't meet the primary endpoint at 12 months, which was about the 6-minute walk test. The trial is still ongoing, so we're going to see what's going to happen next. Let's talk now about TTR silencers. They inhibit or knock down the hepatic production of TTR by blocking the production of the transthyretin. Unstable circulating tetramers are then reduced, preventing organ deposition and potentially leading to clearance of the transthyretin protein. There are currently two kinds of TTR silencer which are commercially available in Canada. You have the antisense oligonucleotide inotersen and the small interfering RNA molecule patisiran. Oligonucleotides are short molecules which within the nucleus of the target cell binds to target messenger RNA. Via RNAs, it initiates messenger RNA degradation, while small interfering RNA molecules are double-stranded oligonucleotides containing sense and antisense strands. The former act as a drug delivery device, and the latter is the active one. Once within the cytoplasm, the antisense strand is loaded with subsequent degradation of the messenger RNA. Both inotersen and patisiran are approved by Health Canada. Two other agents are currently tested in research protocol. You have the antisense inhibitor eplontersen and the silencer vutrisiran. Eplontersen is an antisense oligonucleotide with an identical sequence as inotersen, but with enhanced liver uptake. It's currently tested in two trials, the Neuro-TTR and the Cardio-TTR trials. Both are ongoing studies, but we know from the primary results that the Neuro-TTR trials that the first results are very promising. For the vutrisiran is a second generation small interfering RNA drug that has a high affinity for a receptor which is found in high concentration in the liver. It's administered subcutaneously every 3 months, while patisiran, which is the previous one, is currently an IV infusion every 3 weeks. So the same thing as for inotersen, this drug is currently tested in two different trials, HELIOS-A and HELIOS-B. HELIOS-A is targeting patients with hereditary amyloidosis. HELIOS-B is targeting patients with ATTR cardiomyopathy. Now, there's a technology which is really amazing. It's called the CRISPR-Cas9. In 2020, Emmanuel Charpentier and Jennifer Doudna were awarded the Nobel Prize in Chemistry for discovering this technology called the genetic scissors. It's an approach in which target DNA can be permanently modified or repaired. This technology consists of two components. You have a nuclease called Cas9, which is complexed with a single guide RNA. And this complex is delivered into the hepatocyte through an appropriate vehicle. Once it's in the cell, the guide RNA directs the Cas9 protein to a specific target DNA sequence. The Cas9 protein will then recognize the target DNA and performs double-strand cleavage, leading to the absence of production of TTR. In 2021, 6 ATTR patients received a single intravenous infusion of a drug based on this technology at 2 different doses. It was published in the New England Journal of Medicine. And what this study shows, which is of course a phase 1 study, at 28 days after infusion, TTR levels were reduced from baseline with both doses. The reduction was greater with the larger dose. There was no major side effects described at this point, but we didn't know neither how long this effect will last. Last year, we got part of the answer to that question because the same investigator at the American Heart Association conference shows these data that show demonstrating that after a single injection of the experimental drug, the level of transthyretin protein was still reduced after 6 months of follow-up. So this is really exciting. We're still at an early stage of development, which is promising, not only for, in fact, for patients with amyloidosis, but also for other rare disease as well as cancer. What we don't know if it's completely safe. There's some signal in some other studies which suggest that maybe we could have an increased risk of cancer. But anyway, the whole principle of this technology is really interesting. The third category of drugs for treatment of ATTR amyloidosis, which is currently under development, are anti-amyloid therapies. The goal of these agents is to bind and extract the amyloid substance from the organs and tissues where it's deposited. There is a substantial unmet need for such treatments because many patients with ATTR amyloidosis that we are seeing in our clinic are still diagnosed, unfortunately, at an advanced stage of the disease. Different drugs are currently developed. I'm just going to show you here 2 examples. You have this one, which is NN6019-0001, which binds when TTR tetramers dissociate into monomers and prevents then the formation of new amyloid fibrils. So it acts just before you have the substance within the organ. This other one, the NY006, binds directly to the TTR fibrils and try to clear the amyloid substance. So these 2 agents are currently in a very early stage of clinical development, but could be very interesting in the future. To conclude, ATTR amyloidosis was previously thought to be a rare condition with no treatment, which is not the case anymore. More and more therapies are now available and provide an opportunity to alter the natural history of this progressive disorder. The technologies are incredible, but also very expensive. The cost of this drug must be taken into consideration if we don't want them to constitute a barrier to care or be the source of major inequalities between patients. And we just talked about it earlier during one of the clinical cases, especially if we think about putting 1, 2, or 3 of these drugs together in the same patient in the future. Thank you very much for your attention.
Thanks, François. That was a tremendous presentation and some very exciting stuff. The CRISPR as you pointed out, is especially exciting, and we'll see where that takes us. Maybe I'll just ask you one question, and again, we talked about dual therapy. We've both expressed concerns about the cost. I've been a bit, I guess, dubious about the possible efficacy. However, a lot of the clinical trials now have patients on dual therapy because tafamidis has been established as the standard of care. And therefore, would be unethical really to not have patients. And so, a number of the current trials have patients, the CardioTransform trial, Helios B, and Apollo B, and I think all the trials moving forward. So we will be in a position where we have some data. We'll see what we get. I guess my question to you is, if we, and it's a bit of a crystal ball question, if we look into the future, will we be do you think we'll be possibly required to treat patients with dual therapy in this context? It almost muddies the waters a bit in some ways, having some patients on dual therapy versus not in these clinical trials. So yeah, the question is if you stare into your crystal ball, do you think that's going to influence our regulatory environment and how we treat these patients? And then in particular, the Novo Nordisk one, which has more of kind of a downstream mechanism as opposed to some of the other silencers and stabilizers, which has a very upstream mechanism. So I don't know, what do you think's going to happen? Do you have thoughts on that?
Yeah, that's pretty good question. First of all, I think it's going to, the fact that, as you said, most of the trials, they need to have patients under dual therapy, otherwise it's unethical to propose this kind of studies to our patients. Make that, to show an impact of these drugs in these patients, the impact has to be, the amplitude of this impact needs to be high. So if the trials have a lot of patients under dual therapy and they still show a significant impact, and the impact is just a p-value, it really makes a difference in terms of quality of life, survival of this patient, then yes, it will change our way we are going to manage our patients. It's going to take a lot of work with people who are paying for these drugs to convince them that what they are going to save by paying for this dual therapy in terms of hospitalization, readmission, or death it's a good investment. But yeah, definitely is going to be a change of management.
Yeah, thanks for your thoughts. I agree with you, and it's a fascinating time in the progression of this disease, that we're at right now. And so, we'll see what the future brings. So thanks again for an excellent presentation, François. And
thank you.
Yeah, thank you. We'll go on to our next presenter. I'm just getting an echo here. Andrew, if you can. Our next presenter is Dr. Visram. And Dr. Visram is a hematologist at Ottawa Hospital and an assistant professor in the Department of Medicine there. She completed her hematology training at Dalhousie University in Halifax, and then had subspecialty clinical and research experience in plasma cell disorders at the Mayo Clinic. Dr. Visram holds a master's in public health and epidemiology from Harvard University and joined the faculty in Ottawa in 2021 as a clinical investigator there. Her clinical research is centered on understanding and improving health outcomes of patients with plasma cell disorders, such as multiple myeloma and systemic light chain amyloidosis. And Dr. Visram is also developing a translational research program in Ottawa to develop cost-effective and efficacious immunotherapies for patients with multiple myeloma. So thanks for joining us today, Dr. Visram. Looking forward to your presentation. Oh, you're just muted.
Perfect. Thanks for having me. And thanks for the invite. I've been asked to give a very brief overview on the management of AL amyloidosis as well as some of the emerging therapies. So this will be very high level because it's a very short amount of time. So these are my disclosures. So as most of you know or have heard today, light chain amyloidosis is most often caused by a small indolent plasma cell clone that secretes misfolded light chains that then aggregate into oligomers, that aggregate then into amyloid fibrils, that deposit into tissues and cause organ damage. And so there's really two big approaches in terms of treating light chain amyloidosis. The first is to shut off light chain production by targeting the actual plasma cells themselves. And this is the standard of care for treatment of light chain amyloid. And then the second is to actually target the amyloid fibrils that are deposited in order to facilitate their clearance. But before we go there, I think it's important to note that as we have better availability of novel therapeutic agents, the prognosis of patients with light chain amyloidosis is improving over time. However, there is a population of patients that, despite better availability to drugs like bortezomib, their early outcomes are not improving. And when we look at that subset further, we see that patients with Mayo stage 3B amyloidosis, so those with advanced cardiac involvement, their outcomes are not improving over time. So despite availability of bortezomib, more so since 2010, the 2-year overall survival for these patients is still only 18%. So why, and really this highlights the importance of early diagnosis. So why is that? So I think the principles of plasma cell directed therapy for amyloid are quite different than treating multiple myeloma, which is a cancer of plasma cells, even though we use the same drugs. And part of that is because plasma cells secrete light chains that deposit into organs. It's like someone laying bricks to build a wall. But plasma cell chemotherapy does nothing to stop, it stops amyloid deposition, but it does nothing to clear deposited amyloid fibrils. So once we shut off the amyloid production or the light chain production, the macrophages of the body slowly resorb the amyloid fibrils. So really the goal of treatment is to normalize and shut off that light chain production as quickly as possible to prevent further organ damage. And organ recovery lags behind hematologic responses by months and sometimes years. So those cardiac patients that are really symptomatic at diagnosis, sometimes it's too late to really intervene meaningfully because they already have so much organ damage and can't tolerate treatment. So in terms of first-line treatment for amyloid, usually, as has been alluded to earlier today, the first kind of step is to assess whether they're eligible for an autologous stem cell transplant. And the use of auto transplants in amyloid really isn't supported by clinical trial evidence. There's only been one randomized controlled trial using auto transplant versus melphalan dexamethasone, and it was in 2007, and it actually showed that transplant 25% of patients who got a transplant died within 100 days compared to none in the melphalan dexamethasone group. And it didn't improve heme or organ responses. And the reason for that is that transplant is associated with significant mortality or morbidity given the risk of arrhythmias and infection and renal failure and transfusions and fluid shifts. And so that trial really underscored that it's important to carefully select which patients we send to a transplant. And since then, we've gotten much better about picking which amyloid patients really should go to transplant. And though the criteria differ at each center, most of the criteria are focused at excluding patients with significant cardiac involvement from transplant. And now with more stringent inclusion referral criteria, retrospective cohort studies have actually shown that transplant can lead to deep and durable remissions in systemic light chain amyloidosis. And so in patients that are eligible, we usually, if they have a significant plasma cell burden at baseline, we'll give them induction therapy with a 4-drug regimen, daratumumab, Cybor-D. And if they have a deep hematologic response, so either a complete or response or a very good partial response, we stop. But if not, we go on to a melphalan conditioning regimen, followed by an autologous stem cell transplant. And again, deep responses, we stop and we monitor, but if not, we can proceed to second-line therapy. But the overwhelming majority of patients with amyloidosis are transplant ineligible. And now, quite recently, actually, the standard of care for the fitter patients is a 4-drug regimen called daratumumab Cybor-D, followed by daratumumab maintenance. And I'll discuss that in a little bit more detail in the next slide. And for those patients who have more severe symptoms or frailer at diagnosis, we peel away drugs and we either give them a triplet, so Cybor-D or VCD, as was mentioned earlier, it's the same thing, or a doublet, bortezomib dex or melphalan dex. And deciding on these regimens is really just based on the hematologist's clinical gestalt. So the Andromeda study was a recent pivotal trial that really changed practice for light chain amyloidosis. It was a phase 3 multi-center trial that randomized untreated patients with amyloid to either 6 cycles of Cybor-D, which was our previous standard of care, or Cybor-D plus daratumumab for 6 cycles, followed by daratumumab maintenance. And daratumumab is a monoclonal antibody that targets the CD38 antigen that's specific for plasma cells. So essentially, these patients got about 2 years of therapy. And the primary endpoint of that study was really the depth of the hematologic response assessed by the CR rate, which is essentially normalization of the problematic light chain without any evidence of circulating light chain on immunofixation or excretion in the urine, on urine immunofixation. And as you see in the red kind of highlighted box, adding daratumumab more than doubled the hematologic responses and organ responses. And not only that, the responses with daratumumab were faster, with a median time to a heme CR of 60 days compared to 85 days with just Cybor-D, so almost a month earlier. And we know with amyloid, time is of the essence, so this is actually quite impressive. So prior to this trial, in Ontario, Cancer Care Ontario actually did not fund any treatment for amyloidosis unless patients had concomitant myeloma. But as of September of 2022, so quite recently, Dara-VCD is reimbursed for untreated patients with amyloidosis, which is a huge breakthrough for our patients. But CCO is quite strict about needing to document Congo red positivity. So I'd mentioned earlier that in some patients who we don't find Congo red on a bone marrow or a fat pad, this would be a reason for us to push for an additional biopsy. So treatment of relapsed amyloidosis is actually quite variable, primarily because there's not a lot of good data. It's based on early phase studies or really retrospective case series. And importantly, within our publicly funded healthcare system, these drug regimens are not publicly reimbursed for relapsed amyloidosis, so we depend a lot on compassionate programs and patient insurance. That being said, we do have a couple of treatment principles we keep in mind. One is that amyloid plasma cell clones are different than myeloma in that we don't worry as much about clonal evolution. These clones are indolent. And so often if patients have had a deep and durable response to first-line therapy, we can just retreat with the same original first-line regimen if we are able to access the drugs, which is not something we would do in myeloma. Similarly, alkylator-based therapies, so things like a stem cell transplant at relapse, become an option because sometimes people have had years off therapy and have had that time to have organ responses. So fitness can actually improve with time with amyloid, as we've seen nicely in one of the prior cases. Another option is immunomodulatory drugs such as lenalidomide or pomalidomide, though these have to be used very carefully in patients with cardiac amyloid as they can be difficult to tolerate. More recently, the BCL2 inhibitor venetoclax is showing more promise. This was the idea of using venetoclax came from the fact that in myeloma specifically, patients who have the 1114 translocation seem to do quite well and respond well to venetoclax. And 50% of patients with amyloid have this translocation. And so there have been some retrospective series showing that this is both effective and tolerable in relapsed amyloid patients who are otherwise pretty frail. As you've heard, bortezomib is the mainstay of treatment in amyloid, and that's a class of therapy called the proteasome inhibitors. And so there have been studies with other proteasome inhibitors such as ixazomib, and it really hasn't shown to be much better when combined with standard of care therapy, so we don't use that much. And carfilzomib is a second generation proteasome inhibitor that actually has quite significant cardiotoxicity, and so we don't use that in amyloid, especially not patients with cardiac amyloid. There are some therapies in terms of CAR T therapies that are undergoing some studies, early phase studies in relapsed amyloid, but results of that are pending. So overall, treatment of relapsed amyloidosis is an unmet need, but it's a mixed bag in Canada and really depends on what drugs we're able to access. But if plasma cell therapies can't undo damage that's been done, and obviously, patients that have significant organ damage at diagnosis, this is a problem. And so the next step is to turn to therapies that can actually lead to amyloid resorption. And so I'll briefly discuss these therapies, just keeping in mind that the first two are not available clinically anywhere. So it's still very investigational. So KAL-101 and NEOD-001 are both monoclonal antibodies that bind to the deposited amyloid fibrils, and they opsonize the amyloid fibril, and this leads to phagocytosis and results in clearance of the organized deposits. So in an early phase study, KAL-101 has been shown to be tolerable, and it also results in fast improvements in organ responses. A single arm phase 2 trial has also confirmed the long-term tolerability, most recently in December of 2022. This was shown at our recent ASH meeting. And so ongoing phase 3 studies combining KAL-101 with CyBorD are being studied in patients with advanced cardiac amyloid. Similarly, NEOD-001, there was a phase 3 VITAL study which randomized patients with any degree of cardiac involvement to either standard of care with or without NEOD-001. And the goal was to evaluate the all-cause mortality or cardiac hospitalization. Unfortunately, that trial was terminated because after 103 events, there was really no significant improvement in the primary endpoint with NEOD-001. However, a post hoc analysis of the study did show a survival benefit in patients with advanced cardiac amyloid. And so based on that post hoc analysis, the AFFIRM-AL trial is currently ongoing to study the use of NEOD-001 with standard of care in patients with advanced cardiac amyloid. And lastly, good old doxycycline has emerged as a therapeutic that may inhibit amyloid fibril formation and disrupt deposited fibrils in preclinical studies. But clinically, the data is conflicting. Initially, there was a lot of excitement based on 2 retrospective studies, which had shown a survival advantage with doxycycline. But we know that retrospective studies are fraught with bias. And so recently, a phase 3 study from China has shown that doxycycline didn't improve progression-free survival when added to CyBorD. There's another phase 3 trial that's ongoing, and results are pending. But essentially, though doxycycline is accessible, given that it's unclear how useful it is, we don't use it. So what is the bottom line from a cardiology perspective? I think it's important to underscore that organ responses take time and in amyloid. And so really the best way to treat patients with amyloid is to know when to look for it and to identify it early so that we can intervene before patients are really symptomatic. Knowing that cardiac involvement is often an exclusion from transplant, our mainstay of treatment for patients with cardiac amyloid is now daratumumab CyBorD. This is the gold standard. And while we hope to eventually have access to these antifibril therapies, that's not realistic in the clinical setting in the short term. And I think I just want to underscore the importance of supportive care and being mindful of not only just cardiac amyloid, but the other organs that are involved, given that these patients often have autonomic dysfunction and orthostatic hypotension, decreased oncotic pressure, so blood pressure and fluid management is quite tricky. So that being said, selfishly from a hematology perspective, I really do appreciate having the cardiology and nephrology opinions in terms of managing these tricky patients because of all the multidisciplinary expertise. So I'll leave it there, but thank you for your attention.
Yeah,
thanks.
That's a
great
summary and
the
presentation. Yeah, we were using doxycycline regularly, but have since stopped. And I can just say, anecdotally at least, its tolerability wasn't always that good. We'd have patients with GI issues and a lot of skin issues and sunburns, etc. My question to you is, I put Dr. Tournoux on the spot and asked him to stare into the crystal ball. So I'm going to put you on the spot as well and ask you a question. You talked about the tolerability of stem cell transplant in patients with cardiac involvement and some of the fantastic results with daratumumab and venetoclax is looking very promising. Do you think the days are numbered for stem cell transplant? Do you think it'll go away altogether? Or do you think it's a therapy that we're going to continue to use in select populations for a while moving forward?
Yeah, I think that's a good question. I think we're asking that question even in myeloma, right? I do think that, especially with earlier access to daratumumab, I don't think we need a stem cell transplant. That being said, there is still a small population of patients that may benefit, and those are really the single organ renal amyloid patients who just need one dose of intense chemotherapy, and then they can just be monitored. Remember, with Darosibord, they're on 2 years of therapy, which means they're coming to the hospital regularly. Not only that, it's quite an expensive regimen. 1 month of Darosibord is approximately $40,000. So when you're doing that in the long term, there are, healthcare kind of system implications. And so I think for a small subset of patients, a transplant is still appropriate, especially because it can really give that depth of response. And we're seeing more and more data that's showing that faster, deeper responses, even getting MRD negativity might be helpful in these patients.
Very interesting. Very exciting as well. So thanks again for a wonderful presentation. So I'm going to be talking today about the Canadian Registry for Amyloidosis Research, or CRAR, real-world evidence to advance amyloidosis care. Here are my disclosures. And our objectives for the next few minutes, just briefly, we'll talk about the need for registry data in cardiac amyloidosis. We've touched on this a little bit already. And then, of course, I'll spend most of the time just introducing CRAR, its objectives, its methodology, and also future directions for the registry. So I won't go into this in detail, but we've already heard a lot about the advancements in cardiac amyloidosis, both on the ATTR and AL side. I always like to include a slide like this really to remind myself about how far we've come in a short period of time. It's really quite incredible, all of the advancements that have occurred in both subtypes for this rare disease. It's almost unprecedented, I think, how much interest there is and how much active research is going on. And as we've already heard, there's still a lot more to come in the future. So I won't go into the details because we've heard a lot about this already. But it's been quite a journey that we've been on. And as we heard about, and this is just focusing on ATTR, really, there's still a lot more to come. There's a lot of clinical trials that are actively taking place in silencers and stabilizers and the CRISPR technology and the amyloid degraders as well. And so things are going to continue to evolve over the next few years, and it's tough to keep up. It's tough to keep up, and that's excluding all of the exciting work that's going on the AL side, as we just heard about. So when you have such rapid advancements, and we've touched on this already today, that opens up a lot of gaps in knowledge when these agents come to availability and approval. And so this is just a short list of some of the knowledge gaps that have opened up. Evidence for treating mixed phenotype patients with hereditary ATTR. Disease monitoring, we've talked a little bit about that already. That's still very much a question mark. There's consensus expert recommendations out there, but they're not really evidence-based. And a lot of us are still learning this as we go. Definitions for treatment success and failure are still to be determined. Changing therapy, when do you switch therapy? We had a case on that earlier. Dual therapy, lots of controversy there, asymptomatic gene carriers, and so on. And so here is an article that Dr. Davis in Vancouver and myself wrote about the need for data to drive decision-making and really the rationale for forming the Canadian Registry for Amyloidosis Research. And so, we're going to continue to get data from clinical trials, and some of it will have patients on dual therapy. However, I don't know if that's really going to be enough to really answer the questions that we need answered in a reliable way, or maybe kind of a broad-based way that is applicable to across different settings. And so these decisions are being made right now, and we need further evidence to support them. It's, as often we see, we're also getting a lot of single center studies, and that's common in rare diseases. And they're helpful, but as has been mentioned already, they're subject to bias. Bias in clinical practice patterns and referral and patient patterns. And so hence the need for multi-center collaborative work to really drive the field forward. So certainly, the Canadian Registry for Amyloidosis Research is not the only amyloid registry out there, and more are becoming active over time. This is perhaps arguably one of the better known transthyretin amyloidosis registries that's currently in existence. It's the Transthyretin Amyloid Outcome Survey, or THEOS. This is a global ATTR registry, and it's run and supported by Pfizer. It's been around for a number of years. We used to participate in THEOS. And certainly there's been some very high impact publications that have come out of this registry. Here's one from the Journal of American College of Cardiology, really describing the genotype and phenotype prevalence that were in existence at the time of publication. And this figure just shows, compares the US to the rest of the world and other countries. And we're seeing, as I mentioned, more and more registries pop up, both industry initiated and investigator initiated. Many are regional, and majority of them are focused on one subtype. And so, where does the Canadian Registry fit in this landscape? So I think, and of course I'm biased when I say this, but I think, the CRAR has a unique place in this registry landscape. For one, it's national, truly national, from coast to coast, multi-center registry. It's multidisciplinary, which I think is important. I think, as we are learning more and more, it's hard to think about amyloidosis from a single organ perspective, regardless of which subtype you're talking about. And so CRAR is predominantly neuro, cardiac, and heme organized and managed. And also importantly, there's a patient support group involvement and participation, both from ATTR side and the AL side. It's multi-subtype, so it focuses on AL and ATTR. So of course there are other types of amyloidosis out there, but arguably those are the main ones, the most common ones. And so those are the focus of the registry. It's longitudinal. It has both prospective and retrospective data collection elements, so you can go back and collect retrospective data on patients. Importantly, both live and deceased patients. We have the ability to collect data on deceased patients with a waiver of consent for those ethics boards that permit it. And that helps us kind of get started because, a lot of registries suffer from enrollment bias, whereby, only alive patients are entered, of course, and a lot of events don't start happening until 2 or 3 or 4 years into the study or the registry, and that kind of limits your ability to do outcomes analysis. And so hopefully this will give us an advantage to assess that. I'll talk more about clinical and patient-reported outcomes, but we're entering clinical data as well as having patients complete a survey and enter their outcomes. And also it gives us the ability to contact patients, because we do collect contact information on our patients for those who agree to it. And this has been a challenge with some ethics boards, but we think we're making good progress to be able to contact them for follow-up data, and also to alert them to opportunities with regards to clinical trials and other developments in the field. So broadly speaking, here are the objectives of CRAR. So of course, assemble comprehensive data. And when CRAR was designed, we were just entering into the modern era of these novel treatments. And so really, assessing the availability and impact of treatment is a very common theme and very high priority for the registry, but it's not the only objective. And simply characterizing the population in Canada is also an important objective, as we don't really know that at this time. But yeah, assembling comprehensive data on real-world care, the care setting that patients are being treated in, and defining the impact of treatment on clinical symptomatology, comorbidities, and mortality is an important objective. Advancing our understanding of outcomes, as I mentioned, understanding treatment outcomes is both in the short and long terms is a very important priority for the registry. And then arguably, this might be the most important objective, which is a platform for collaboration. And so what we've really seen is that the registry is bringing together a community of amyloid care providers across Canada, and helping us to really establish a network from which we can collaborate together on other projects in a multi-centered way, which of course is very important for amyloidosis and a rare disease. And from this, we've seen regional groups forming and networks, and actually now there's a group that's working on forming an amyloid society based on kind of the recognition of all of the providers across Canada having a lot of needs and care gaps. And so CRAR has really been a nice platform for that. Here is our team. So myself and Dr. Davis, cardiologist in Vancouver, UBC, are the lead investigators, co-PIs. And then, as mentioned, our multidisciplinary steering committee, Drs. Donna Reese and Chris Venner, hematologists from Toronto and Vancouver, Dr. Delgado, cardiologist in Toronto, Dr. Vera Brill, a neurologist in Toronto, Dr. Stephen Baker, physiatrist in Hamilton, and Dr. Geneviève Giraldo and Dr. Rami Massey, cardiologists and neurologists in Montreal. And also, as mentioned, we have representation from persons with lived experience and our main patient support groups in Canada, hereditary/transthyretin amyloidosis and ATTR support group, and the Canadian Amyloidosis Support Network, and AL support group. So here is our registry website, and this is our platform for data entry and enrollment. You can review this if you like. There are, of course, some functions that are only available to participating patients or clinical sites, but it also gives you some information about the registry in general if you're interested in looking at it. So as mentioned, we have both clinical data entry platform and patient-reported outcome measure platform, which we'll talk about a little bit later on. The clinical data describes, again, looking at treatment and clinical symptomatology, and in particular, focus on outcomes of care, of treatment and their comorbidities and mortality data, and the patient-reported outcomes, which we'll talk about a little bit more, kind of focuses on symptom burden, quality of life, and impact of disease. We currently have 4 sites who are fully active and enrolling patients across Canada: Calgary, UBC, U of A, and Halifax. And we've got a number of other sites, particularly those represented here, who are pending and becoming active. I think the numbers there are actually a bit dated that you see. We've got over 150 patients consented. I think that's probably an underestimate at this point. We've got a deceased cohorts that we're not quite sure how large it is, but is likely sizable. And then we've got patients who are now participating in the patient-reported outcome measures platform as well, which is very exciting. We're beginning to produce some knowledge translation outputs, even though it's still very early on. In addition to the article that Dr. Davis and myself published, there was an abstract. These are mostly methodology abstracts, but abstract presented at the American Society for Hematology late last year and published in Blood Journal. We've had abstracts submitted to the American Academy for Neurology and the Canadian Neurosciences Federation, and also we'll be sending them to some cardiovascular meetings. What we're hoping is that, this year we're actively onboarding a lot of sites and getting data flowing, and we're hoping that really in 2024 we'll have a very significant data set that we can actually start publishing some outputs, particularly with respect to prevalence and characteristics of the Canadian population. And so there's a number of projects that have been proposed. I've already kind of touched on some of the priorities of the registry, so I won't go into these in great detail. But we really want this to be a collaborative effort across Canada, and what we want is people using the data set and trying to answer questions that perhaps our committee yet hasn't considered. And so we kind of view this as a collective data sets, and everyone here who's joined is certainly welcome to propose ideas. We have, of course, a scientific committee to review, and we want this to be as collaborative and across Canada as possible. And just kind of touching on the comment I made earlier about creating an amyloidosis community in Canada. The registry, I think we've seen the registry helpful as a vehicle to support our support groups, and our support groups have been helpful in supporting the registry. So again, building that community, we've seen guideline position statements published, and I think this can really help to put Canada on the map globally for contributing to amyloidosis advancement. So I'll end there. So in summary, there is an ongoing need for high quality longitudinal data for patients with both subtypes of amyloidosis, and in particular in the context of all these exciting new therapies. CRAR is a multidisciplinary national registry for collecting clinical and patient-reported outcome measures for patients with AL and ATTR amyloidosis, and it brings together the Canadian amyloidosis community and helps to create a network for further collaborative initiatives. So thanks very much for giving me the opportunity to talk about CRAR, and we can have a minute or two to talk about, answer any questions or comments.
Yeah, I just think this work is so important. I mean, we talked about it at the plenary session this morning. These diseases are so rare. The only way you're going to learn anything about them is by collaborating and combining information. So this is essential in my mind, what you and Margot are doing to help understand this. So I encourage anyone who's not part of this to take part if they're seeing amyloid patients. I can't emphasize how important this is. I mean, it's important from a patient care perspective. It's important for knowledge growth, and then it's a platform for study. Like, we can launch some studies from the registry as well. So, do you know, Nowell? Have you? Are there plans to connect this registry with any of the other amyloidosis registries? Like, are you in touch with the UK people at all? Or do you know, for example, Mariana Fontana, who's a CMR person who works at the UK National Amyloidosis Centre? There are links being established?
Yeah, not formal links yet. Certainly, you know, conversations with colleagues, both at investigators at major centers, as well as colleagues in pharma and industry who are running amyloid. And I think there's a general recognition that, as you say, you know, we need to pool our data, and you know, that's the best way that we're going to learn. You know, in the last year or two, we've really just been focusing on getting ourselves up and running. I think, like everything else, COVID threw us for a loop, and we had to kind of pause things for a while. And now we're getting our momentum back. And I think once we have really a significant data, a foundation, then we'll be reaching out to our colleagues, you know, across the world, and certainly, you know, lots of kind of, you know, side conversations and informal discussions about the importance of this. And I'm hopeful that actually that'll be our main focus in next year, once we've got the majority of our sites onboarded this year.
And the other quick question, and then maybe Alissa can weigh in on this as well. Chris Venner in the past had said that there was an amyloid registry as well. Is that still in operation? Is that, and if so, you know, what are the links there? Like, is there a Canadian amyloidosis registry?
Alissa, do you want to weigh in? It might be the CRT that he's referring to.
Yeah, so there's a myeloma registry, the CMRG registry, and we're starting to incorporate all plasma cell disorders into that registry, but we don't have any patient-reported outcomes in there. So we could potentially, I imagine there's some overlap because a lot of the treatments and baseline characteristics are in there, but it is a little bit different.
Yeah, it's a little different than I think Alissa and certainly Donna and Chris Venner are important members of those initiatives. And when we designed CRAR, we tried to make it complementary to the CMRG, and you know, add some additional information about organ responses that's very specific to amyloid. And so we've had lots of conversations with Chris and Donna also about sharing and linking data. It's always in practice more challenging than it sounds, but recognize that there's a lot of value to it. But CMRG also gives us a nice platform to promote CRAR. Oh, you're just muted, Alissa.
Sorry, my Teams keeps going back and forth, but Calgary has Victor Zapita. I don't know if you know him. He has a big interest in MGUS and amyloid, and they have a local registry there, but he has actually set up an MGUS clinic where they screen patients for amyloid. So he might be someone to connect with as well.
Yeah. Oh yeah. Victor really well. communicate kind of weekly. So
we haven't kind of looped in his MGUS clinic just yet, because a lot of those patients don't have confirmed or they don't have confirmed amyloidosis. But I think certainly that's a potential pool for patients. I think the other part is that CRAR is dynamic, and we recognize that as the field is progressing so quickly, we're going to need to make changes and adapt. And I think this will be
our challenge, and also an exciting potential area for us as we move forward in such a rapidly evolving environment. And so populations like MGUS, will be important considerations for us. And, we're going to need a lot of input from our community to guide us on how best to evolve the registry over time.
Margot, did you want to make any comments about the registry as well?
I really don't have much to add, though, to Noel's excellent presentation. I think we're in a really exciting phase of the registry right now. I feel like we're just accelerating. Things are starting to really take off. We're getting the patient data into the registry. We're bringing sites on board really quickly. So yeah, it's exciting times for us, and really looking forward to seeing what comes out of the next short term, sort of next several months, and then moving forward and hoping that that we can bring more and more of the country on board with us, so that we can really form a fully representative sample of the Canadian amyloidosis population. Great meeting, by the way, Ian, congratulations.
Thanks. By the way, I look forward to the site meetings in Vancouver or Calgary coming up for CRAR.
Yeah, we're keen to get Ottawa.
You're missing the West already, are you, Ian?
Yes. Okay, so with that, I thought we should talk. Noel talked about this a little bit, so did Alissa, about patient-reported outcome metrics. So in the last minutes of our session, I thought we should talk about that. So I have a few slides I'm going to share first, and then Noel also is going to share something. So let's see if I can get my slides working here first. So yeah, I thought we'd talk about patient-reported outcome measures, what's being used in cardiac amyloidosis. And let's see here. These are my disclosures. And to be honest, I'm among the people working in amyloidosis who know the least about this. But it's something that I recognize and I want to change. Basically, patient-reported outcome measures are a form of health questionnaire, often used to gain the patient's perspective, and it can be to gain their perspective on lots of things, including their health status at some time point in their illness. And it can also be used as well to gain insight into how well they think your services are being delivered to them. So there's something called PROM, which are patient-reported outcome measures, and PREM, which are patient-reported experience measures. This is something, as medicine moves more towards patient-centered care, these measures are going to become more and more important, both clinically as well as academically in research. And the other thing I'll say is that these outcome measures do, in some clinical situations, predict outcomes. So, as you guys in this room are probably aware, there's a lot of health questionnaires used or that have been used in heart failure. Many different questionnaires, and I'll mention one in a moment. And these questionnaires do, in fact, show reasonable predictive power for predicting heart failure outcomes. And there are other benefits to using these questionnaires as well, which we'll discuss. Basically, my understanding is there's two types of questionnaires. There's the sort of more generic type questionnaires, which gets asked questions about general overall health status. And then there are some that are more condition specific. And there are pros and cons to using each one. Okay, so we'll just have a look here at the next slide. So this I mentioned this earlier. This is some data from the UK National Amyloidosis Center, and Kai talked earlier about what do people do in terms of surveillance of their survivors or people on therapy with amyloidosis. And at this center, you can see, I don't know if this is still their protocol, but they were doing every 6 months for people with ATTR. They were doing labs, ECG, echo, 6-minute walk time, and then they were doing a quality of life questionnaire, and one of them was the Kansas City cardiomyopathy questionnaire. So that was being something that was administered every 6 months to patients in their cohort. And a couple things, you can see that it did show some change over time. So that's the advantage of these questionnaires, is they can be administered each time they come for their appointment, and you can compare scores to how they were the previous time. One of the interesting things I want to draw to your attention is that they reported their data on 711 patients, but then if you look at the fine print on the figure, it says that they only had data available on the patient-reported questionnaires in 158. So there was a lot of patients that they were missing this data on. And it sort of begs the question why, and it wasn't really clear. Some of it may have been they only started doing the questionnaire after 2010, but it still sounds like they were missing data on quite a number of people. And so, in terms of using or adapting a questionnaire that was developed for heart failure and adapting it to another patient group, it's potentially problematic. And so some of the problem areas include there's a low number of participants here, and it makes me wonder, were they just pressed for time? In my case, when I worked in Edmonton, one of the reasons I didn't administer this questionnaire is in addition to not having as much knowledge as I probably should about it, is I didn't have any personnel to help. So it may have been time, personnel issue. And then the other thing is the patients have to see worth to doing this questionnaire. If they don't see any value, for example, if you're handing them a piece of paper and asking them to fill something out and then never discussing it with them, I think that over time they begin to question its value. Okay. And then the other limitation of using these type of questionnaires is if it hasn't been adapted for a specific group of patients, you may not be capturing very well the nuances of their disability or their symptoms. And again, it hasn't really been validated for capturing symptoms in the other disease groups. So in getting back to that question of time, interesting thing, I didn't know this, there are two versions of the Kansas City cardiomyopathy questionnaire. One of them has 23 questions and the other version has 12, so half the number of questions. And this is an interesting study which showed in heart failure patients, the shorter version, which is in orange, seemed to perform just as well as the longer version in blue in terms of predicting changes in health status from one visit to the next. So you can see here when there's a big change and a big improvement, according to the clinical team's impression, the orange form performed arguably better than the blue there. So longer is not necessarily better in some circumstances. So maybe our questionnaires are too long. And then in amyloidosis, there are no, to my knowledge, specific questionnaires developed for amyloidosis. I emailed a colleague in the UK, Dr. Mariana Fontana, 6 months ago and asked her, and she said nope, she didn't think there was. In the literature, I can't find any, but there are some that are used. There's the PROMIS, which is used. It's adapted for, it's been developed to measure patients with chronic disease, but people have been using it and publishing on it in amyloidosis. There's also the Pro-CTCAE, which is another patient-reported outcome questionnaire, which was developed by the NCI, a branch of National Institutes of Health, to help inform on tolerability or adverse events related to cancer treatment. So patients that Alissa is giving her medications to, are they developing any intolerances or side effects from those medications? And then I believe CRAR is using the SF36 form, which stands for short form. I don't know how short actually it is, but it measures the overall health status of a patient. And it's, from what I can tell in the literature, it's most commonly used for AL amyloidosis. So there's all kinds of different generic forms that are being used or adapted to amyloidosis. And we saw, obviously, the UK center was using the Kansas City cardiomyopathy questionnaire. So do we need specific patient-reported outcome measure forms for amyloidosis? Arguably, yes. I mean, there definitely are some pros. Like we saw earlier, we have a form that's being used that's just capturing the cardiac component of their symptoms. And then it wouldn't necessarily capture anything about any of the other systems that are affected, the neurologic or any other system. And it doesn't really capture any side effects of their treatment, some of the specific therapies that they're receiving. And if we had forms that were able to, capture the nuance. So if someone was fatigued or had lower exercise tolerance, but we had a form that could help us decide if it was more in the neurologic area versus cardiogenic, that would be really helpful, especially when we're deciding, potential change in therapy. Some of the cons, and they're big ones, is a lot of the forms that are being tried, especially the ones that are custom made, so people are coming up with their own forms, they really haven't been validated, meaning, okay, we have a form, we think it's going to capture numbness, so neurologic issues, but no one's actually validated it to prove that the form actually will capture what it says that it's capturing. So there are tests you can do to validate these forms. The other thing is that these forms have to be reliable, meaning that if I administer the form in Ottawa and Nowell administers the same form, or we administer the form at 2 different times, what is the inter-person reliability or inter-study reliability and reproducibility? And it also has to be responsive, meaning that if a person's clinical status does change over time, will the form be sensitive enough to detect those changes? So these are all things, that a newly developed form needs to be validated for or assessed, undergo a suitability assessment. And then one of the disadvantages of a specific form is it's harder to compare how well or how not well your patients are doing relative to patients with other diseases. So one advantage to using the more generic forms is you can compare an amyloid patient to a heart failure patient or other patient groups. So that is an advantage of a generic form. So I read some places are actually applying a specific form and a generic form, which sounds like a lot of work, but you could understand why some places might choose to do that. And so, if there was an ideal patient-reported outcome measure form for amyloid, I arguably would be disease specifics, and specifically would capture AL or ATTR. So I don't know, that may require 2 different forms. It would have to be, as we discussed, validated, reliable, responsive, and it would have to be easy for patients and healthcare providers, so ideally not onerous in terms of the length of the form. And at the end of the day, both the treating team and the patient would have to view that it enhances the care. Okay, so I just had some questions, Bonnie. I don't know if you're able to help launch these polls, but and I actually don't know, Freya, if we use any forms in Ottawa to assess how patients are doing when they come into the clinic. I wasn't doing it in Edmonton, although that should change hopefully now that we have CRAR up and running there. So I'm asking this question to the audience. So does your program use health questionnaires when your patients come into the clinic? Do you have any sort of health questionnaire to ascertain how they're doing on that given visit? So, I don't know if everyone else sees this, but most places are a no. So I'm kind of surprised. So Nowell, are you the only one who's doing this? It appear.
Well, I answered yes because we're trying to get patients into CRAR, and I'll talk about the CRAR patient-reported outcome survey shortly. So I don't know, maybe I was cheating a little bit, but other than CRAR, no, we don't use something that's specific. And
okay,
and I'll talk about a little bit about that. We dabbled with it, but we really wanted to steer patients towards CRAR. So we didn't want to overburden them.
So I guess this next question only applies to you. So you're using the SF-36, I would guess. Is that right?
Yeah, correct. That's the validated part of the CRAR patient-reported outcomes that we're collecting. We are collecting a few other questions from them and information. But yeah, it's SF-36.
So what would the people who are not using these forms, can we find out what would be the major barrier? Is it poor knowledge about these forms? Is it just lack of time and personnel? Is it unsure if it really adds value? Or you tried it and it just was never being filled out? So if we could launch that question. I can enter my own answer here, so I'll do this. Yeah, so it's pretty much everyone saying the same answer so far, which is they didn't have the time and personnel to do it. So I have some thoughts about that, but maybe what we'll do, Nowell, is we can come back to that issue after you discuss a little bit about some of the health outcomes measures you're collecting.
Yeah, sounds good.
Let me just stop sharing. Is this something, Nowell, that would have to be collected as part of a clinical trial for patients in clinical trials? I would imagine so, right?
Yeah, and most, I shouldn't say most, the trials that we've participated in have all included some patient-reported outcome measures, and they've typically been, the generic or validated ones already, and nothing amyloid specific. So I know the KCCQ is figured prominently in our cardiomyopathy amyloid trials. But yeah, no, we don't really have one that's validated for amyloid.
Mm-hmm.
So you can see my slides okay?
Yes.
Yeah. Okay. So yeah, I'll talk a little bit about this as well, and mostly talk about CRAR. And as Ian kind of mentioned, probably my main disclosure is that I'm not an expert in this area either, and there is a lot of expertise that's needed to do this properly. And so I can talk about what we've done and what I know, but this is an area that has to be done with a lot of care and expertise. And I also think that might be a barrier, is that those who are experts or have a lot of interest in amyloid may not necessarily have expertise in patient-reported outcome measures. And so when we try to do it, we may not collaborate as much as we should with those who do. But we do have some experience. So yeah, I'll touch on, I mean, Ian talked about a lot of these concepts already, so I won't repeat it, but some of the, the challenges with rare diseases and patient-reported outcome measures, and then talk about some that are out there, what's going on that I know of, and talk about what we're doing with CRAR. And so, I've learned that this is quite an active area of academic medicine, is patient-reported outcomes for patients with rare diseases, and there's been a lot written and published on it. And I think the bottom line from looking at some of these articles, and I've just kind of randomly put a few of the titles up here, is that as Ian mentioned, it is a challenging area, and of course there's thousands of rare diseases. And very few patients have them. And so the main barrier is proper validation of disease-specific patient-reported outcome measures for rare diseases. And that in general, they are preferable, but the generic ones also work pretty well. And so, that's kind of what a lot of groups and trials who are using them fall back on, because the work's already been done to validate them. So there are some disease-specific patient-reported outcome measures that have been designed. And here's just an example of one for Gaucher's disease that was developed and validated. And I won't get into the details of what's in that survey or their process, but it is a lot of work. However, once it's done, it provides a resource for the entire field to use, both for clinical monitoring purposes and importantly for clinical trials. And as mentioned, what's out there currently in the amyloid world, whether it's neuropathy or cardiomyopathy or patients with AL and malignancy, is been the generic or already validated questionnaires, whether they're for cancer or for neurology or cardiac, and the KCCQ as an example. Okay, so what are we doing currently with CRAR? So yes, we do have, as I mentioned, a patient-reported outcomes measure survey. It takes about 15 to 20 minutes to complete, and patients can go onto our website and self-enroll and take the survey. Once they've self-enrolled, then they're in the system, and they get annual reminders to complete the survey moving forward, so that we have longitudinal data to compare with over time. How was this developed? Well, it was developed kind of the same way as the clinical data set was developed, which is through an iterative process through the steering committee. And as mentioned, this is a multidisciplinary committee, but we do have patient support group representatives. And of course, for this in particular, they played a very important role, both in fine-tuning the questions and then also assessing the online platform for its ease of use, and how user-friendly it is. A lot of our patients are older, and so may not necessarily be as computer savvy as younger populations, and so it's out there, it's being used, but importantly, it is an unvalidated study, with, of course, the exception of the quality of life component, which is the SF-36. And so we've kind of added to the list of surveys that are being used that are not validated out there to assess this. But we did go about it in a systematic way, and broadly speaking, our objectives were to assess burden of disease and also to assess perspective on disease. And so burden of disease would include a lot of the things that you would think: symptom burden, quality of life, living status, are they independent or do they need supports? What's their level of function? What's their degree of impairment? There are questions there about the financial implications of their disease, and also what kind of supports they require, family, friends, or otherwise? Are they part of support groups? And then perspective on the disease, some questions to understand their diagnostic journey, which has been well described as often very challenging in the literature, and common, of course, for many rare diseases. Their access to healthcare, where the setting of their amyloidosis care, where are they being managed, and by whom, and in what regions. Of course, trying to assess their response to treatment, overall satisfaction for care, and also to some point trying to understand their understanding of their own disease, and do they know what they have, and do they know what they're on. And that's particularly helpful, when we have patients who are enrolled in both the clinical and the patient-reported outcome measures, which is our goal, is to have them involved in both, comparing their responses, with their clinical assessment. So yeah, so I've already showed you this, and so I won't belabor this, but here's our website and the online platform, and so here's what it looks like on the right, and patients go down and complete the survey. And the survey is divided into sections: sociodemographics, symptom burden, symptom impact, questions related to diagnosis, questions related to treatment, quality of life using the SF-36. And then we developed a COVID-19 questionnaire when COVID hit, and we tried to kind of get on that very quickly. Actually, we've just had some discussions about that, and it's probably, well, not just probably, it is dated already, and we're wondering whether we need to continue with that or not. But currently, we do have a COVID-19 questionnaire to assess its impact on patients' overall amyloidosis care. So just quickly, what else is out there? Well, there's lots of stuff out there, but again, none of it's really validated. So, I just put this up really just for kind of discussion and consideration. This is a survey that our Calgary amyloid program put together a few years ago, and it's a short list of questions to assess symptom burden and also medical history. This was actually not designed as a patient-reported outcomes measure survey. It was designed to help care providers identify important symptoms and to give them a tool with which to inquire about them. So, for example, cardiologists may not know the best questions to ask in screening for neuropathy. Neurologists may not know the best questions to ask in screening for cardiomyopathy. And then there's also a third one that focuses more on the constitutional symptoms like weight loss and fatigue, etc. And so as we were designing it, we actually felt, okay, well, this is actually something that patients can just fill out themselves, and maybe that has more value. And so we produced this. Again, as a patient-reported outcome measure, it's unvalidated. We're in the process of validating it as a screening tool for amyloidosis, and it's specific to ATTR. But that's, of course, a very different thing than patient-reported outcome measures. And so we're not kind of using this in our clinic since CRAR has come online, because we really want, again, patients to be directed to CRAR, and we're worried about overburdening them with surveys. But we've made this available, and certainly we're happy to provide this to any clinic that wants to use it. We know that there are some out there that are using it, and we're very happy to share. There's also a French language version of it as well. So, that's another survey that exists. And then the Amyloid Research Consortium is a very large and well-funded organization in the United States, or ARC. And they do a lot of work in amyloidosis, and really they're a tremendous organization. And this is one of their initiatives, also an ATTR quality of life survey. That's patient-reported outcomes. Similarly, patients would log in to the ARC website and complete this online survey. And I don't actually have the elements. The survey is now closed. I asked them if they could provide me some of the questions that are included in advance of this presentation, but they didn't get back to me. So I don't have it. I know it has a heavy focus, of course, on quality of life, but on some of the access to care issues, particularly in the U.S., such as insurance access and how that impacts their access to therapy. So this is kind of in the process of being validated, and it hasn't been published yet, but I would expect in the coming months that it will be. And this might be a tool that, who knows, maybe becomes the standard for ATTR quality of life in the future. And so that was kind of really it. And that's my summary. So amyloidosis specific patient-reported outcome surveys have been created, but really with minimal, if any, validation for currently what's out there. We are using a tool in CRAR. We hope it's beneficial, we think it'll be interesting to see. But I think the case with amyloidosis is similar to other rare diseases where we kind of fall back on generic validated quality of life surveys and patient-reported outcome measure surveys. And really further research is needed and collaboration with experts in this field to systematically design and validate these tools in amyloidosis and other rare diseases. And it's an interesting question that you pose. How should we be doing this or not? How necessary is it for the field, and does it even need to be fine-tuned into subtypes and then predominant phenotype and system involvement or not? So all very interesting areas for discussion. So thanks very much, and we can talk a little bit further about it.
So I'll put you on the spot. So were it not for CRAR, if you had just a regular clinical patient that was not in CRAR, not in a clinical trial, would you be collecting these measures? And would you be doing any sort of quality of life measures on these patients, or patient-reported outcome measures?
Yeah, I don't know, to be honest, Ian. I suspect we wouldn't be, because I think we would really need, as you talked about, a very clear understanding in our own minds that we can tell the patient about how we're going to do that. I think just doing it for the sake of doing it, maybe, is questionable. And that's why, we weren't using the questionnaire that we produced within our own program, which again wasn't really designed as a patient-reported outcomes measure. That said, I think it's easy to overlook this, in our clinical practice. And for all the reasons that you've described. But I think there's a recognition in the literature, as I learn more about it, about how important it is in not just kind of managing our patients, but also establishing how we deliver care. It really does have an important role, in things like frequency of assessment and follow-up and testing. All of these things put time and burden on the patient, right? And it's really important for us, I think, to understand their perspective, especially at this point in the disease's evolution, as things are moving so quickly, so that we can really do things as optimally as possible. So I've kind of dodged your question a little bit, but I think in the future, I think our CRAR is a good tool. We put a lot of thought into it, but we didn't have expert input into it, and I think that's probably our next step as in the evolution of CRAR.
Yeah, I mean, I do think, as you point out, this is something certainly that's discussed more and more in the literature. So I think it's coming. Where I do think it could be helpful is because patients are giving feedback about how they're doing in specific areas of their day-to-day living, it helps discussions around treatment. So like if you have a patient who's struggling in one area, let's say numbness, and not as much in heart failure. If you have the form in front of you and the patient has filled it out correctly, it's, I think, easier to have a discussion with the patient about the therapeutic choices there, right? So you say, listen, this is coming from you and it's hard to ignore. So I think in that sense, you know, it empowers the patient a bit more in helping to make health decisions when there are different options.
Yeah. No, I agree absolutely. So I'm really actually happy that you put this topic into this session, because it is really important. And I think, you know, it's helped me to also kind of frame how we move forward and think about this area, even as we do it for CRAR.
I mean, it also gets back to this notion of, well, there's a lot of being written now around patient-oriented care and patient-oriented research and personalized care, for that matter. Like, if, you know, if this is what the patient is experiencing from their viewpoint, I think it's in many cases hard to ignore.
Yeah.
So maybe it just means we've all become terrible history takers. I don't know.
Yeah.
I don't know. Yeah, I thought I wanted to, because I selfishly, there was a project I was thinking of doing before I left Edmonton, which would have required the use of patient-reported outcomes, and I did a bit of looking into it, and there was nothing. So I thought, well, maybe it would be good to have a discussion around that and see what other people thought. But I do think it's something that it may lend itself well to amyloid, just because of the multi-system nature of the disease and the chronicity of the disease, and the complexity with some of the therapeutic decisions that are being made, right? So
absolutely.
And not to mention end of life decisions as well. So
yeah, all important, and, you know, especially with some of the challenges. I think you make a very good point. You know, in some of the challenging clinical decisions that we have to make, you know, we really have to kind of include the patient's, you know, voice in them, particularly when there isn't really good data to support it, and we're doing our best for clinical judgment, right? So it's a really kind of important advantage to having something like this.
Anyway, so yeah, I wasn't sure. I honestly thought most places were using these, and I thought I was in the minority, but I guess I'm pleased to see I'm not the only delinquent. So. But all right, any other thoughts? You know, I guess we have. I was actually. So does anybody here in the room see themselves using these healthcare questionnaires outside of? I guess they're going to have to if they're part of CRAR, right? So.
Well, hopefully, yeah.
I think in Edmonton, the only group that was using these was our heart function group, and they were, I'm not sure even if it was being consistently collected. You know, they were doing health questionnaires with patients when they would come in.
Well, you know, Ian, I don't know, I didn't look but at the schedule, but, you know, you've got a number of other rare diseases also represented at this conference. You know, it might be interesting to ask that question.
That's true.
And hear, what's going on in
sarcoma.
You know, I suspect it's very similar, but I would be curious to hear.
Alissa, did you want to tell us your experience?
I just had a question, because I do think it's an important initiative, but I think the logistics make it hard to implement. And so I just want to know, in your kind of clinics, how do you do it? Do you give patients like an iPad during the waiting room, or is there a way to push a link through MyChart and Epic just to increase the number of people that are actually going to go home and fill out a survey?
So I'll tell you for CRAR, the consent form has the website. Our approach is to, when we consent a patient for the clinical side of the registry, then we talk about the patient-reported outcomes side. We point out, here's the website, and go into it when you get home. And not all of them do, of course, and then some of them have questions, and they can contact the registry to address those. But they take the consent form home with them, so they have a piece of paper that reminds them of the website. So that's the way we're doing it. The patient support groups have also, as I mentioned, have been very good at promoting this. So we've had a few kind of, I guess I'd call them de novo people just kind of find the registry and complete it on their own, just through awareness through the support groups. But that's been the approach that we've been using thus far.
And the other thing I guess I'll say is Nowell has a colleague in Calgary, James White, who has a company he's developed called Cohesic, and they have developed tablet technology that you can give to a patient in a waiting area. It's mainly been designed for patients waiting for diagnostic imaging tests, but on that tablet, you can have questionnaires preloaded. So while they're sitting in the waiting area, they can fill out a consent form to say they consent to be part of a registry. They can fill out a quality of life questionnaire. They can fill out a safety screen to undergo the MRI test. And so basically what that involves is a unit clerk handing them the tablet, and then there has to be somebody from your team available in case they have a question. Normally, my understanding is there are not questions, but someone still has to be available, to go talk to the patient if they have a question about it. And apparently they have a pretty good uptake. I'm told, for their registry, they had close to between 85 to 90% uptake. So it didn't seem, so that would be an option, I guess, is what I'm saying, is if we had good tablet technology, like in waiting areas, this may be more feasible, right?
Yeah, no, they've certainly had a lot of success with that, and that's something for us, I think, to consider for CRAR in the future.
Just need more money.
Always.
iPads aren't that expensive. Yeah. They haven't gone up as food items, so that's good.
No, it's true, yeah.
A lot, much appreciated. And appreciate all the speakers today. You all did wonderfully and all came to help on relatively short notice, so much appreciated. The next year we'll have a bit more lead time. Thanks also, Bonnie. We'll try to get the advertisement out a bit earlier next year so we have more people. I reached out. I don't know the amyloid group so that well here in Ontario yet. No, I reached out to several of them and they were busy. But we should have more participants in the. Again, thanks to everybody for coming, for your support, and yeah, next year we'll be hearing about how CRAR has enrolled how many patients next year, Nowell?
Next year, hopefully thousands. No, we're hoping to get. We think we can get over 1,000 enrolled across Canada. So that's kind of a nice target for us, and I think this time next year would be a good time to check back in. So thanks very much for organizing it. It's a great conference. It's very interesting and unique, and it's been a pleasure to be part of it.
All right, everyone. Thanks again. Have a great weekend.